today we are going to talk about thyroid gland, and we are also going to talk about diseases of another gland, which is known as a parathyroid gland. Okay, so as the name suggests, it is parathyroid. That means it is situated next to the thyroid, and that is why it is called as parathyroid gland. Now, the job of the thyroid gland is basically to control the basal metabolic rate. Okay, so let us see what kind of a gland it is. Okay, thyroid gland, when we say, let us see what kind of a gland are we looking at. Now, this is how the thyroid gland is. It is a butterfly-shaped gland. And where is it located? It is located around the trachea. Okay, it's located around the trachea. So, there are two lobes. Okay, so one of them will be the right lobe, one of them will be the left lobe. So this will be the right lobe, this will be the left lobe. The part in between the two lobes is called as the isthmus of the gland. The part which joins the two lobes is called as the isthmus of the gland. All right. Now, approximate weight will be anywhere between 20 to 25 grams. All right. Now, what is important? It is situated in the neck. And as we know, it is an endocrine gland. Okay, endocrine gland. What do we mean by endocrine gland? It has got a good blood supply. It does not have a duct system, and hence its secretions are hormones. And these hormones are released into the blood. And what happens is that these hormones circulate throughout the body. These hormones circulate throughout the body. And at some point, wherever these thyroid receptors are there, they will pick up these hormones and action will begin. All right. So this is what we mean by an endocrine gland. Now, if we are to look microscopically, each unit of this gland, is made up of follicles. All right. So each unit of this gland is made up of follicles. This is how the follicles are going to be. This is where you're going to get blood vessels. This is where you're going to get blood vessels. All right. And in between, this is where the secretions are stored. Okay, so these are going to be the cells of the follicle, which are initially columnar, but as the secretions start accumulating, they keep pushing the cells and then these become cuboidal. So initially they are columnar cells, which later on become cuboidal. All right, and it has got a rich blood supply. Inside, we have what is known as thyroglobulin. As the name suggests, what does thyroglobulin? Thyroid hormones plus globulin. They are bound to globulin, and hence it is called as thyroid binding globulin. Okay, thyroid binding globulin. Now, what mineral is important for thyroid hormone formation? It's iodine. Iodine is that mineral which is important for thyroid hormone formation. All right. Now, let me ask you this question. All right. Tell me which of the amino acids is an aromatic amino acid. All right. So, I have put in a poll for y'all. If you can see. All right. I have put in a poll for you all. So can you try to answer that? Which is the amino acid, which are the amino acids which are aromatic amino acids? Do you understand what I mean by aromatic amino acids? Their structure has got a benzene-like ring. Okay. These are called as aromatic amino acids. Can you see the poll? Are you able to see the poll? I've created a small poll for you all. Yes. All right. Okay. Yes. So, is only one person able to see? Yeah, whoever is able to see, please. I think there are 31 people. At least 20, 25 people can attempt answering the questions. Yeah. So name the 3 amino acids which are aromatic amino acid. And which are the ones? So 3 amino acids which are aromatic amino acids are phenylalanine, which is the second one. It is the tyrosine. And which is the third one? Tryptophan. So the next question I've asked in the poll is which amino acids are essential amino acids? What do we mean by essential amino acids? Essential amino acids are those amino acids which cannot be made by the body. So which of these are the essential amino acids? Yes, yes, yes. Okay, some more people trying to answer. So out of these essential amino acids are phenylalanine and tryptophan. And which is the non-essential amino acid? It is tyrosine. Tyrosine is a non-essential amino acid for the simple reason that, all right, for the simple reason that this tyrosine can be made from phenylalanine. Okay, this can be made from phenylalanine. Now, when this tyrosine combines with one atom of iodine, it is called as monoiodotyrosine. And when this tyrosine combines with 2 atoms of iodine, it is called as diiodotyrosine. Monoiodotyrosine is also called as T1. Diiodotyrosine is also called as T2. Okay, diiodotyrosine is also called as T2. Now, when T2 combines with T1, we get T3, which is known as triiodotyrosine. And when T2 combines with T2, we get T4, which is known as tetraiodotyrosine, which is also called as thyroxine. All right. So the actual thyroid hormone which is working in our body is T3 and T4. Okay, T3 and T4. Triiodotyrosine. Okay, it's thyronine, sorry. Okay, triiodotyrosine and tetraiodotyrosine, which is also called as thyroxine. All right. Now the question is, if you see the ratios, which is more? So T4 is much more than T3 in the body. The ratio is almost 20:1, 20 times T4 as compared to T3. All right. But the thing is that which is more active? T3 is more active than T4. T3 is more active than T4. And hence, whenever T4 wants to act, it has to get converted to T3 and only then the action will take place. All right. When T4 has to act, it has to get converted to T3 and only then the action will take place. All right. This is important. So see, thyroid produces T3, that is triiodotyrosine, and tetraiodotyrosine, which is also called as thyroxine. All right. So when we are giving supplements, we give T4 supplements or thyroxine supplements. All right. Now, 5-D iodinase converts T4 to T3 in the peripheral tissue. As I said, every time T4 has to act, it needs to get converted to T3. Only then it will be able to act. T4 itself does not have much of action. All right, so this is the enzyme which is required, 5-D iodinase. Now, which are the drugs which inhibit this enzyme? So glucocorticoids, beta blockers, and propylthiouracil. These are the drugs which block these enzymes and prevent conversion of T4 to T3. So if we are facing with a problem of hyperthyroidism, where the thyroid hormone is excessively active, we can give these drugs. These will prevent T4 being converted to T3. And we know that T4 by itself doesn't have much of action. Most of its action is because of this conversion to T3. All right. So that is why this is one way in which we can decrease the effect of thyrotoxicosis. Right? Then we have something called as reverse T3. Now you must have thought, why is it that I am writing T2 plus T1, T2 plus T2? Why not write T1 plus T2? So if T1 combines with T2, now that is important because in chemistry we have spatial configuration. So when T2 combines with T1, it forms T3, that is triiodothyronine. But if T1 combines with T2, that means the same two molecules, but in a reverse spatial direction, then it gives rise to what is known as reverse T3. Reverse T3. Now, what happens when there is reverse T3? This is a product which is metabolically inactive. Okay, so remember, T2 has to be combined with T1. T1 getting combined with T2, that means the same two molecules, but in opposite spatial directions. What will happen is that there will be reverse T3, which is inactive. All right, inactive. And if you have a lot of growth hormone, glucocorticoid, what are they going to do? Instead of formation of T3, they will promote formation of reverse T3. All right. Now, there is another enzyme called as thyroid peroxidase. So two important enzymes that we studied just now. What is it? 5-D iodinase. This is one enzyme that we studied. The second enzyme that is very important is thyroid peroxidase. This is a very important enzyme, thyroid peroxidase. Why? Because this is practically responsible for almost every step that is required in thyroid hormone formation. So, whether it is oxidation, whether it is organification of iodine, or whether it is coupling of monoiodothyronine with diiodothyronine, everything is characterized by thyroid peroxidase. So imagine one enzyme you block and you are practically stopping the thyroid hormone formation. One enzyme you block and you're practically stopping the thyroid hormone formation. That means this is a very, very, very effective site of action if you want to treat hyperthyroidism. 5-T iodinase catalyzes only one step. Okay, so it will have a limited effect if you block it. But if you block thyroid peroxidase, almost the entire T3, T4 formation will stop. Now, again, which are the drugs which are going to do that? Propylthiouracil and methimazole. And hence you will realize that when we are treating hyperthyroidism or thyrotoxicosis, then the drugs that we give are propylthiouracil and methimazole. These are the primary drugs that we give. Beta blockers, glucocorticoids, they are all additional drugs which help us to control the hyperthyroidism or thyrotoxicosis better. But mainly what we are going to give is propylthiouracil and methimazole. Now, physiologically, there's one effect that we have to study, and that is called as 𝗰cie𝘂𝗃𝗃's effect. What is that? If there is sudden exposure to excessive iodine, temporarily thyroid peroxidase will be turned off, and that means there will be decreased T3 and T4 production. So if you suddenly give a lot of iodine to any person, what will happen is that there will be decreased T3, T4. What we expect? We expect that there will be increased T3, T4 because iodine is required, right? But that excessive iodine, because of chemical effects, is going to inhibit thyroid peroxidase. And in fact, T3 and T4 levels are going to be lower. All right. So that is giving rise to 𝗰cie𝘂𝗃 effects. Right? That is important. Now, let us see what are the functions of thyroid hormone. So one thing, okay? One thing. Can you see there are 5 B's over here? And rather 6 B's also there, babies. It's so easy for you to remember. Now, one important thing that we always say is that it regulates basal metabolic rate, the rate at which metabolism takes place. Now, the question is, how does it do that? It does that by increasing the activity of sodium potassium ATPase. Okay, sodium potassium ATPase. If you look at any cell, this cell has got excess of potassium, and outside the cell there is excess of sodium. Outside, extracellularly, sodium is more, intracellularly, potassium is more. So naturally, what should happen? The sodium should try and get inside the cell, and potassium should try and go outside the cell. That is known as the natural or normal electrical gradient. But if that happens, if the whole thing stabilizes, a lot of processes in our body will stop. Many processes in our body, including nerve conduction, takes place because there is imbalance. So to restore imbalance, what we need to do is that we need to have a receptor which is going to throw sodium out of the cell. Okay, it is going to throw sodium out of the cell, and it is going to get potassium inside the cell. Naturally, what has to happen? Potassium has to go out of the cell, and sodium has to come inside the cell. But we have this this particular receptor or this particular channel which gets potassium inside the cell and sodium outside the cell. Now, how does it do that? It does it against the electrochemical gradient. It's against the electrical gradient. Okay. Naturally, sodium has to come inside and potassium has to go outside. But here we are doing exactly ulta. And when we are doing such thing which is against the electrical gradient, we need energy. And who provides us energy? ATP. When you break one bond of ATP, you will get energy. Okay, so you need an enzyme which breaks ATP so that energy is released, and this energy provides us helps us to take these ions across. And so we want something that gives us energy, and this is what we call as the ATPase. Okay, so sodium potassium ATPase pump. Okay, what it does, it puts potassium inside, back inside, it takes sodium back outside, and this is against the electrical gradient. This is creating imbalance. And so we need energy. Energy comes from breakage of ATP. So ATPase, sodium potassium ATPase pump. Can you tell me any other pump that you know of? Have you heard of something called as hydrogen potassium ATPase pump? Hydrogen and potassium ATPase pump? Have you heard of this? All right. So tell me, in which organ do you see this hydrogen potassium ATPase pump? Which organ do you see this hydrogen potassium ATPase pump? Hydrogen potassium ATPase pump. Kidney. Okay, yes, you do see it in kidney, but more importantly, in which organ do we use drugs against it? We use drugs to block this hydrogen potassium ATPase pump. In which organ? Tell me. Yes, yes, that's right. That's right. So it's in the stomach. It's in the stomach. It's the final pathway or the final process of acid formation, hydrochloric acid formation. The hydrogen for that hydrochloric acid comes from sodium potassium ATPase pump. Hydrogen potassium ATPase pump. Okay, so that is why we have. It is also called as proton pump, because hydrogen is a proton. Only hydrogen ion without electrolytes, without electrons, is just proton. So it is called as proton pump, and hence we use drugs to inhibit this. They are called as proton pump inhibitors. All right. So here we are seeing sodium potassium ATPase. So what it does is that when the basal metabolic rate increases, oxygen consumption increases, respiratory rate increases, and body temperature increases. The other thing that T3, T4 is required for is brain maturation. So this is very, very important in children, especially neonates, because we will realize that when there is hypothyroidism in neonates, then there is mental retardation because the brain does not grow properly. It is required for bone growth along with growth hormone. It is required for blood sugars in this regulation. So last time we saw that there are certain hormones which are diabetogenic. One of them is T3, T4. And what do? They increase the glucose. How? By breaking down the stored form of glucose, that is by glycogenolysis. And secondly, what do? They cause gluconeogenesis. That means they will convert other things to glucose. What are the two things that are converted to glucose? One is the proteins, and the other one is the fats. So for fats, what happens is actually fats are not converted. It is basically the fatty acids which are converted. Proteins are not converted, but it is the amino acids which are converted. So to get fatty acids, what do? We have to break the fat, giving rise to lipolysis. See over here, lipolysis. And over here, proteolysis. Proteolysis. The proteins have to be broken into amino acids so that the amino acids get converted into glucose. All right. Then what it does is that it stimulates surfactant synthesis in baby. What is the surfactant? It is the one which decreases the surface tension so that the lungs can expand properly. Now, if that is not there, then there will be respiratory disease of the newborn. Okay, that is one thing. Secondly, it has got beta adrenergic effects. Okay, beta adrenergic effects. Now, let me use this. Adrenergic receptors. Adrenergic receptors, if we see, they are of two important types. They are alpha and they are beta. Alpha are again two types. They are alpha 1 and alpha 2. Beta are again three types. Beta 1, they are beta 2, and they are beta 3. All right. So alpha 1, the most important effect of alpha 1 is vasoconstriction. Most important. Okay. Apart from the eye effect and the mydriasis and all that is other different. But vasoconstriction. Alpha 2, basically, it acts against the against the adrenergic system. So at the preganglionic area, it inhibits the system. Beta 1, what does it do? It increases the heart rate. Increases the heart rate. Beta 2, what does it do? It causes vasodilatation. It also causes bronchodilation, vasodilatation. Sorry, it causes vasodilatation. Beta 1 causes bronchodilation. Okay. So this is the effect. What is the effect of beta 3? Beta 3, basically, it is used, the agonist of beta 3 is used for overactive bladder. They cause the bladder to become slightly toned. Okay. So there is something called as mirabegron, which is a beta 3 antagonist, which is used for overactive urinary bladder. Now, what happens is that it has got beta 1 effect in the heart. So what it does is it increases the heart rate, and as a result of it, it increases the cardiac output also. Okay, stroke volume. What is stroke volume? The amount of blood that is pumped by the heart, okay, per contraction. So that is also increased. All right, contractility of the heart is increased. Various investigations in a thyroid disease. Now, one of them is thyroid antibodies, thyroid autoantibodies. Where will you see thyroid autoantibodies? This is a condition called as autoimmune thyroiditis. Now, there are antibodies against the thyroid cells and they will cause destruction of the thyroid cells. What are the antibodies? Thyroid peroxidase antibody and thyroglobulin antibodies. Okay, thyroglobulin antibodies. What will happen? They will cause destruction of the thyroid cells, and as a result of why? Because of autoimmune thyroiditis. Hashimoto's disease is the commonest cause, which we will study in some time. Then we have something called as Graves' disease, in which there is a TSH receptor antibodies. Now remember, these are not the destructive variety. These are the stimulating variety. we saw in the previous slide, okay, the slide before that, that when free T3, T4 is in large quantity, what happens? TSH is inhibited. So less TSH is secreted, and hence the cells do not have to secrete more T3, T4, and everything gets balanced. But here what happens? These antibodies, this look exactly like TSH. Okay, so these antibodies look exactly like TSH. So this is a TSH receptor, this is a TSH receptor. All right. Now what it does is that it goes and sits over here instead of TSH. It looks exactly like TSH. So as a result of which the receptor feels that TSH is sitting over there and the cell secretes more and more T3, T4. So though the actual TSH is not being secreted, but because of this antibody, the cells get a wrong signal, and that causes more and more T3, T4 secretion, giving rise to thyrotoxicosis. This is something called as Graves' disease. FNAC, fine needle aspiration cytology, is good to detect malignance. Okay, good to detect malignance. Now, nuclear scan and ultrasound. Now, remember, nuclear scan is good for thyroid nodules, okay, nodules in the thyroid, which are solid nodules. Solid nodules in the sense what? When you do a sonography, there are two types of nodules that you might see. One type of nodule, which is cystic nodule. Cystic nodule. See over here, you will see. You will see cystic nodule. It tells you cystic nodule. Where is the sonography? I don't know where it is written over here, but a sonography is good to detect a cystic nodule. Okay, it's a fluid-filled nodule, and it can differentiate. Sonography can differentiate between a cystic nodule and a solid nodule. When there is a solid nodule, we will do something called as nuclear scan. What will we use? We will use 123 iodine, 123 iodine, and we will see the uptake. Now, there are two important types of uptakes. One is called as a hot nodule, and one is called as the cold nodule. Okay, hot nodule and the cold nodule. So suppose, okay, like this. What is the difference between hot and cold nodules? When the nodule takes up more radioiodine compared to the rest of the gland, we call it as a hot nodule. And that means it's a hyper-functioning nodule. Whereas when the nodule takes up less radioiodine as compared to the rest of the gland, then we call it as a cold nodule. Now, what is important is that many of these cold nodules, almost 20% of these cold nodules can be malignant. Okay, so one has to be very careful. The moment you see cold nodule, you will send for an FNAC to see whether it is malignant or not. Hot nodule means that it is hyper-functioning nodule. We need to remove it or ablate it. All right. If it is a cystic nodule, we can aspirate it. So ultrasound is number one, good for cystic nodules. Secondly, it is good for something called as multinodular goiter. What do we mean by multinodular goiter? As the name suggests, multiple nodules. But many a times what happens is that when the patient presents to us, we can palpate only one nodule. When the patient presents to us, we can palpate only one nodule. And when we do sonography, we see that there are multiple nodules. In that case, we call it as a dominant nodule. The one which we were able to palpate, we call it as a dominant nodule. And this goiter, we call it as a multinodular goiter. Now, what do we mean by goiter? Goiter means enlarged thyroid. Goiter means enlarged thyroid due to any reason. Just like when the spleen gets enlarged, we call it splenomegaly. When the liver gets enlarged, we call it hepatomegaly. Similarly, when the thyroid gets enlarged, it is called as goiter. Okay, so goiter is another name for an enlarged thyroid. Now, so multinodular goiter is when there are multiple nodules. And if we can feel only one nodule, then we call it as a dominant nodule of the multinodular goiter. A CT scan, why is it important? CT scan is important for something called as retrosternal extension. Sometimes the thyroid gland becomes so heavy that it gets pulled into the thorax. So it comes to lie behind the sternum. It's called as retrosternal goiter, which is one of the indications for surgery because it keeps pressing upon the nerves, pressing upon the veins and the esophagus and trachea. All right, trachea. Can anybody tell me what is the kind of trachea that we see when when the goiter presses on the trachea? When the goiter presses on the trachea, what is the shape of that trachea? There's a special name for that. Anybody can tell us? Can anybody tell me when the goiter presses on the trachea, there's a special name for that? Anybody? What trachea is it called as? What is it called as? It's called as a scabbard trachea. What do we mean by scabbard? The place where you keep the sword. In Hindi, they call it myan, myan. Ek myan mein do talware nahi reh sakti, na? That kind of myan, whatever is there, that is called as scabbard. Okay, so it's called as scabbard trachea. Now let us go to the real stuff. Let us go to hypothyroidism. Now one more poll I have made for you. Today I was trying how to do make poll. So this is another poll for you. Okay. So there's one question which must have come as a poll. Try to answer it. So half a minute, maybe half a minute, 30 seconds. Many people are answering it correctly. Right? 5 seconds more. Anybody wants to attempt? All right. So yes, quite a number of people answered it correctly. The answer is, what do we see first? What did we say? We first see TSH. So when it is hypothyroidism, TSH will be high. When there is hyperthyroidism, TSH will be low. Okay, so the TSH will always go in the opposite direction of the name. So when you call it hypo, TSH will be high. And when you call it hyper, the TSH will be low. So TSH will always go opposite to the name. And T3, T4 will always go according to the name. But remember, whether it is hypo or hyper, we don't decide on basis of T3, T4. We decide on basis of TSH. What do we decide on basis of T3, T4? Whether it is primary overt or whether it is subclinical. All right, that is important. So, hypothyroidism, hypothyroidism. So, is prevalent in elderly women mostly. Most of the thyroid problems are seen more often in women. Now, what do we mean by myxedema? Myxedema means accumulation of mucopolysaccharides in subcutaneous tissues. And that is why you will see that those people who have hypothyroidism, their skin is usually thick, all right, because of this accumulation. Sometimes even their voices are hoarse because of this accumulation of mucopolysaccharide. What could be the causes? There could be transient causes, okay, like thyroiditis. Now, what happens in thyroiditis? If you see the graph of thyroiditis, no, you will see that in most of the thyroiditis, thyroid levels rise and they come down like that. So if this is the normal level, this is the level at which they are euthyroid. This is when they are hyperthyroid. And this is when they are hypothyroid. So in most cases of thyroiditis, you will see that there is a small phase of hyperthyroidism, phase of euthyroidism, and a long phase of hypothyroidism. Why does that happen? Because thyroiditis, as the name suggests, is inflammation. And because of the inflammation, there is destruction of the thyroid tissue. And as a result of which, whatever thyroglobulin had accumulated, that starts pouring into the blood. And so hyperthyroidism happens. And because thyroid is being destroyed, the thyroid gland is being destroyed, new thyroid hormone production does not take place. So there is a time when this excess hormone gets exhausted, and slowly and steadily that person moves into the phase of hypothyroidism. So when the person is moving from hyper to hypo, there is a small phase when that thyroid hormone levels will be normal, and that will be called as phase of euthyroidism. All right. Then the other causes of hypothyroidism could be radioactive iodine treatment. All right. When the gland gets destroyed because of radioactivity, thyroid surgery, when you have removed, and a very common cause called as Hashimoto's thyroiditis. Again, inflammation, but because of autoantibodies. And what will happen in hypothyroidism? See, there will be hyperlipidemia because lipolysis takes place. Hyponatremia may be there. There will be increased in creatinine kinase. Why? Because there's going to be proteolysis also. Okay, transaminases might be increased. All right, there might be anemia. Okay, pernicious anemia. Why pernicious anemia? Because this is most of the time it is autoimmune. Pernicious anemia is also autoimmune. So many of the autoimmune diseases go hand in hand. So, in your examination, what is the clue to tell you that there is a hypothyroidism? If you have a lady who is tired, who has a husky voice, and who has cold intolerance, then you call it as you are thinking in terms of hypothyroidism. All right. Which are the people who are at risk? If there is a history of Graves' disease, if you have over-treated the patient, if the patient has autoimmune disorders, other autoimmune disorders, all right, in hypothyroidism, what is important? TSH. TSH will be elevated. In a clinical variety, T4 will be low. All right. And if both are in the same direction, that means there's a problem with the pituitary. Cholesterol may be raised. There might be anemia. The ECG might show bradycardia, low voltage, or flat T waves. So how do you treat? First, you will confirm the diagnosis, and you will provide appropriate patient education and refer the patient wherever appropriate. Okay. So remember one thing, before you start T4, see to it that the person does not have ischemic heart disease, because if the person has tachycardia, then there will be a problem and this person will not be able to tolerate. When there is tachycardia, what happens? There are two things, okay? Because of tachycardia, there will be decrease in systole and decrease in diastole. Can you tell me what is the main thing that is happening in diastole? What is the main event in our body that happens during the cardiac diastole? There is systole and diastole. Systole is when the heart contracts, diastole is when the heart relaxes. Can you tell me what is the main event in our body that happens during diastole? That's right. Absolutely. So cardiac perfusion, which means that the coronaries are supplying blood to the heart. Now, if there is tachycardia, what will happen is that the systole and the diastole both will decrease. And if the diastole decreases, the heart will get blood for a shorter time. In a normal person, you can still tolerate it, but if a person is ischemic heart disease, it is not tolerable. If a person has hypoadrenalism, what happens is that this is a physiological stress, and a physiological stress will not be able to be tolerated by someone who is hypoadrenal. Okay, this we will study next time when we do adrenal. So remember that why is this important? Because if it is problem with the pituitary, hypopituitarism, and when adrenal also is not replaced, okay, adrenal hormones are not replaced properly, then what will happen is you start treating T3 by thyroxine, there might be tachycardia and this person will not be able to tolerate it. It will cause an adrenal crisis. Once you have cleared everything, what you will do, you will start with levothyroxine, which is 50 to 100 microgram daily, increase by 25 microgram up to you reach a maximum dose of 100 to 200 micrograms. Okay, this you should increase only if required, not that you keep on increasing. You titrate it with TSH. What is our aim? Aim is to achieve levels of 0.5 to 2 milliunits per liter of TSH levels. All right. This drug has to be given empty stomach. All right. Monitor TSH levels firstly at 6 to 8 weeks and then maybe 2 to 3 months. And when everything is okay, then you can do it at 2 to 4 years, 2 to 3 years. And treatment is usually lifelong. As long as the person is alive, you have to give this. So if the person has ischemic heart disease, don't start increasing thyroxine rapidly. Do it very, very slowly. If the person is taking thyroxine, then during pregnancy and postpartum, continue thyroxine, okay? But watch for hypothyroidism. That is a possibility. If you are doing an elective surgery and if the patient has become euthyroid, you can stop thyroxine for 1 week. And if the person is still not controlled, then till the person becomes euthyroid, don't do an elective surgery. There is something called as myxedema. What happens is that this is an emergency. Your hospitalization in ICU is required. You may have to give parenteral T4 or T3, all right, by slow IV. Okay, there can be coma, extreme hyperthermia, areflexia, respiratory depression. Okay, and what are the precipitating factors? It could be infections, trauma, cold. So any stress factor. So now let us see hypocalcemia. One of the cause could be injury to the parathyroid, severe vitamin D deficiency, autoimmune hypoparathyroidism, okay, whatever. Now, the most common cause of hypocalcemia is hypoparathyroidism, okay, which is usually secondary to surgery, post-thyroidectomy or parathyroidectomy. There is a condition called DeGorge's syndrome where there is aplasia. Parathyroid is not developed properly. All right. So what happens is there can be twitching, tetany, muscles will go into spasm, contraction that is seen. Or if you tap the angle of the mouth, there will be spontaneous uh, contraction. There will be spontaneous contraction. All right. So that is known as Schostek's sign. Tapping over the parotid causes twitching of the facial muscles because the nerves are hyper excitable because of calcium problem. Another thing is Trousseau's sign. So if you, put the blood pressure cuff on the arm and inflate it, then what will happen is that the muscle will go into spasm. So it will look as if it's a obstetrician's hand. It is called as obstetrician's hand. Okay, as if the obstetrician is trying to do a per-vaginal examination. Now, if there's hypocalcemia, what will you do? You may have to give calcitriol and calcium to correct hypocalcemia and see to it that you don't cause hypercalcemia in the process. Now, if the patient is symptomatic, paresthesia is there, hand, feet, person goes into tetany, then you would want to give IV calcium. Okay, IV calcium. Okay. Also, if the calcium levels you do and they are less than 1.9 millimoles per liter, you will have to urgently give calcium. How do you give calcium? You usually give 10 to 20 ml of 10% calcium gluconate in 50 to 100 ml of dextrose intravenously over 10 to 20 minutes. You can otherwise give calcium chloride, okay? But it is more irritating to the veins. So you should give it through central line. Now, if the person is asymptomatic, if the calcium levels are above 1.9 millimoles, or if there is a latent tetany, which means that person doesn't present with anything, but you go and tap and there is twitching, or if you go and put the blood pressure cuff and there is this. So you can give oral. You don't need to give IV. So when will you not give IV? When the patient is asymptomatic plus serum calcium is more than 1.9 millimoles per liter or latent tetany. That means patient is not presenting, but you try to find out whether there is tetany and you found that there is mildly twitching. That is the time when you will give oral.